Good morning, everybody, and welcome to another vertical integration session. Today we have Dr. Ellie Warren and Dr. Catherine Pumpwood with us to talk about hospital in the home. Thank you so much for joining us. It's really lovely to see you. I would love to start by acknowledging the traditional custodians of the lands that we all live and work on. I'm on beautiful Darkinjung land and pay my respects to elders past, present, and emerging. Just to remind you that this session is being recorded and we will be posting it up onto the Education Library, that we have an evaluation, which I'll put up at the end of the session. And please feel free to pop any questions you have into the chat, but we will have plenty of time for you to actually ask those questions and have a discussion. So with that, I'd like to hand over to Ellie to start. Thank you.
Thanks, Sandy. Thanks so much for having us this morning too. It's wonderful to be able to share some of the stuff that we're doing on Hospital in the Home and Central Coast Health at Home. So let me just click through to the first slide. Yes, thanks for that beautiful acknowledgement, Sandy. We are very privileged to be calling in from Darkinjung country too, so I'd love to acknowledge that. And so we wanted to sort of do a bit of a formal introduction, and then I'll throw to Catherine to talk through some case studies this morning, and hopefully by the end of the hour you'll have a good idea and understanding of how to use us to avoid hospital for your patients. There's so much we can do together. We haven't really marketed to GPs just yet before. We haven't been ready to, but this new service is fully flying now. So we're excited to present this to you today. So these are some pictures of our team. We have about 60 staff now, nurses, allied health, pharmacists and doctors, admin working to deliver these services that all come under Central Coast Health at Home. So we are HITH, Hospital in the Home, and we are also the old RACE program that you might have heard of, which is now just a blanket term that we don't use anymore, HITH Allied Health, looking to keep people safe and independent at home. And a lot of elderly, frail people come under that program, but also young people needing intensive allied health support to keep them out of hospital. We've got our virtual care and triage team, or VCAT that we call them. They're expert nurses who are all ED trained to provide some extra support to you as the usual GP, and I'll talk about them a little bit later in the talk. They're a really underutilised team and will be a really great addition to what you can provide from GP land. We also have the aged care response team, which is a wonderful team of 2 nurse practitioners and RNs that keep people out of hospital from aged care facilities. So this is sort of a more detailed overview of who we are and what we do. We are based at both Gosford and Wyong hospitals, and we're a 7-day-a-week, 12 or more hour a day service, and we've just got some new targets to hit 57 admitted beds. So you think of us like a virtual ward. So we're an inpatient program, so we would be just like a cardiology ward or a gastro ward, but we see our patients in their home. So we can access all the same services as inpatients do, and we treat our patients like they are part of the hospital. So Catherine and I are the medical directors. We job share with GP staff specialists, which is an exciting term, newish term and unique to our area. And we have a team of about 8 doctors, senior doctors on our program, GPs, geriatricians and gen med, and 2 JMOs now, one at Gosford and Wyong, to help with the patient load. Nursing, we've got about 40 nurses spread across that vast area on the coast. It is almost twice the size of Singapore is the area that we cover, and we've got pharmacy at both sites. A big allied health team now, which has just been such a wonderful addition to what we can do. The VCAT team is quite small, and the ACART team I've already talked about. So I mean, I guess we're looking after about 70 or 80 patients to keep them out of hospital on any one day. And we see about 180 patients a month through our HITH service alone. So we're doing some really cool stuff now. So we are an admitted model, as I mentioned. So we're really built to pull people out of hospital earlier than they otherwise would, as long as they're safe to be recovering at home. And we would love to just bypass ED altogether. So that's why we want to work with you guys to cut people off before they even step into the facility. So we take people from everywhere, really, GP land, New South Wales Ambulance, aged care facilities and urgent care, just to make sure we can save those hospital beds. So we're only adult service at the moment. We do take the occasional stocky 14-year-old, but generally 16 and over, as long as they are stable enough to be at home. That means they don't need more than twice daily intervention. So we typically visit them once a day in the home with our nurses, with our doctors servicing from off-site. Really, we do a lot of virtual care and see people in our clinics face to face. We love to be doing more home visits, but we don't have the staff to do that just yet. But yeah, so I guess the first question would be to you guys, like, why can you think you would like to use us? Maybe pop some things in the chat. What would be the good things that you can think about a program like this where people are recovering at home? And Georgia, maybe you can keep an eye on the chat because I can't see the chat box, and let me know when I could go, maybe offer up some details. You can think about yourself and why you would want to not be in hospital if you're sick.
So Alma and I snapped cellulitis, so we put the same message in. It's always a good one to start off with.
Yeah.
And then we've got a patient who's clinically stable but requiring long-term IV antibiotics, so I suppose like pneumonias as well.
Yeah, definitely.
Or osteomyelitis. Do you have those?
We do have all sorts of things. So I'm thinking this time maybe not so much about the conditions, but why would a person not want to be in hospital? So you can think like maybe you don't like the bings waking you up all night, that sort of stuff. So we'll go through. Patients love us, really. They really just love being at home instead of hospital. There are all sorts of reasons to stay out of hospital. So we have much fewer hospital-acquired complications. So what are those sort of things that we're thinking when we're thinking hacks?
Gordo's put something in the chat about that.
The uncomfortable beds and noise on the wards.
Yeah, for sure.
Then, Aboriginal and Torres Strait Islander patients who want to be closer home and closer to their families as well. We've got family needs, childcare. Obviously home visits don't happen in general practice as much, so this is a good option. Patients with dementia. Oh, Gordo, pets at home. People don't want to leave their pets.
Brilliant. No, you guys have come up with a much better list than I have here. So that I'm going to steal some of those suggestions. That's really wonderful. So yeah, we do have a lot of people who just want to be at home with their pets, actually. That's a reason why people discharge against medical advice, because the dog's been at home for 3 days without anybody feeding them. And they can continue work sometimes if they're well enough, get to their appointments. And we try to avoid them missing our appointment for the hairdresser, but it has been known to happen. Really the big one for the health system is that it keeps the bed flow moving. And we like to market ourselves as better value care. We do have better outcomes for some conditions. People get better faster at home, and we're not necessarily cheaper than a hospital bed, although we certainly are at the moment. But better outcomes and better value is how we're trying to market ourselves. So this is a slide from the clinical services plan. You can just see how important, it might be small to read, but how important we are in, I guess, solving some of these problems that are going to hit our health service on the coast in the next 5 to 10 years. So much more people, more people needing ED and surgery, medical admissions, all sorts of issues that mean that there are just no more bricks and mortar hospital beds to service the growing need for healthcare. And this is quite alarming. This slide, Richard Broom shared this with us recently in a talk. He's one of the public health staff specialists at the hospital, and you can see that you know, there are people over 75 migrating to the coast to retire here. So we're actually have an increasing population over 75, and we think probably 1,000 people over 75 a year are going to move here in the next 15 years. They're all going to need GPs, and we've all got closed books that about 1,400 of them will need nursing home placement, and we know that those nursing homes are capped at around 4,000 beds only at the moment. So this is sort of crisis times about to hit us, and you can see by these projections that the ED load and the medical admission load is just going up and up and up. So really, we're projected to be in big trouble, really, is the message. Wyong and Gosford hospitals are both at capacity now. We do a daily meeting on our service to look at bed flow, and really most days now they're either in code red or code black, meaning that there's just no movement at all through ED or the hospital. So we need to try and discharge just one person from a ward to create an extra bed for that person needing to come in from ED. We had one day in July where we were on code yellow. That code hasn't been called in 20 years, meaning that there are no ambulances available for call outs to the beach. If you have a heart attack, all the ambulances are stuck in ED. There's literally nobody coming to see you. So that's sort of the day-to-day situation at the moment. And so you can see HITH has been built to try and reduce that demand on inpatient and ED services. And this is how some of the exec have pitched us. This is it's supposed to be you, Catherine, as coming. We're coming to the rescue.
A lot more like you, Ellie.
I was supposed to say HITH across the front of the chest, but I couldn't get AI to understand HITH. But you know, I guess we have to look at ways to keep people at home, and the hospital are trying to find 45,000 extra bed days of care in the community. So that means GP land, it means urgent care, it means HITH and virtual care, any way that we can keep those people out of hospital. So this is a slide really about most of what we do. This changed a little bit. It's only two months old, but we've increased complexity even since this slide was made. So about 50 of our 180 patients a month are long-term IV antibiotics, so septic joints, bone and joint infections, infective endocarditis, that kind of thing. We do lots of short-term IV antibiotics, cellulitis on the money, pyelonephritis, community-acquired pneumonia, lots of hyperemesis now. We've become the experts in HG management, and heart failure is newish to us, and we're becoming quite good at that. Day one hips and knee replacement, we can take people out of hospital on day one for recovery, and a lot of what we do now is that allied health cohort, so people keeping them safe and independent at home. So that's like a lovely service that can fast track access to Transpac and Compacts to get extra meal and transport assistance, and facilitate people being able to stay safely at home with access to home care packages. And CP will talk about that a little bit more. This is just an overview of our virtual care and triage team. So these are meant really, it's just such a wonderful team to work alongside GPs. So I actually use them almost every Friday when I'm there practicing in GP land, to manage that classic sort of exacerbation of COPD on a Friday afternoon. I'm worried about my frail lady who's 80, and I'm going to start some steroids and perhaps, you know, have a go at some oral antibiotics, and I'm not sure which way she's going to go, but I'm not there over the weekend. So I will hand over to our VCAT team, who will call her tomorrow. They can call her twice twice a day if they need. They can actually deliver a little SATS monitor to her home, watch her blood pressure, and then either escalate her to the HITH team if she needs IV antibiotics, or get her to hospital if she's deteriorating. And then they safely hand her back to me when I'm back in general practice. So you could use them just over Saturday, Sunday, to watch your patients who you're worried about. So they're a little known team, but they really have high value. So maybe take a screenshot of this one. Chris has kindly been helping us update health pathways. Thanks, Chris Thaler, for that. So they'll be live in the next couple of days. But we love an email to our intake inbox and a call through to our HITH SMO. So we've got someone on call 12 hours a day to have a chat to you about your patients and whether they'll be suitable for us. So if you're not sure, just call us. We really want to make it easy for you guys to refer. So just a standard letter is all we need when trying to get rid of any fancy forms and make it super easy for you. So Chris has kindly made this decision-making tree for HITH. It's quite complicated. We want to keep it just really simple. So there are some absolute exclusion criteria you can imagine. Like we can't take people who are septic, and you know, a bone or tendon on view or needs to go to ortho. They're just using common sense. We can't really have people who are needing home oxygen who aren't already on home oxygen. So if their SATs are too low, then we'd rather have them in hospital. So some people will get you to send them to ED for a workup, and then we'll take them straight out of ED back to their home. So it's quite easy for ED to do that workup, and then and we get them back under HITH instead of getting them into a ward bed where they're hard to retrieve. Actually, once they hit that hospital system, we struggle to pull them out. So we much prefer to take them before they even get there. But the main message here is just call us. Call us and we'll try to get your patients on. So I hand over to CP there, but maybe if there are a few questions, we can have a quick chat before we get into the cases.
Yeah, there was just a few comments you mentioned about obviously patients going through HITH. Sometimes they have obviously they have a better outcome. Which conditions in particular have a better outcome?
Yeah, we would say definitely cellulitis and some of the short-term IV antibiotics. We want to get those frail elderly patients out of hospital as soon as possible because they're the ones that are more likely to have a fall in hospital, get DVTs, become constipated and confused and decondition really quickly. So that sort of cohort are ideal for HITH. CP, have you got any other comments around that?
Yeah, it's hard to find the data. Something that we're broaching into now is heart failure. So I guess it depends what we mean by who's doing better. So there are KPIs. Is your length of stay better? We kind of average a little bit better to better for most things, but like the long-term IV antibiotics like osteomyelitis, it comes from an ID physician and it's a set term of treatment. So we don't make much difference between hospital management for things like that. But certainly if we look at HAC, so the hospital-acquired injuries or infections or side effects, we are having that benefit of seeing someone in their home and seeing what meds they're on. That's been a big difference. So it's broaching that gap between hospital and home for some of these important things where things can go wrong. Falls are less, DVTs less, delirium like Ellie mentioned. So it depends how you want to measure. Are you better at home? Are you better in hospital? We pay very close attention to our patients and the governance over it. So nothing's flagged as being certainly worse than being in hospital because Ellie and I wouldn't offer that on the service. So I'd like to think that for almost everything that we do, we're doing better, hopefully, than being in hospital.
And then Dimity had a question. Don't forget to unmute, Dimity.
I thought I'd unmuted. I'd probably muted it. I work at Barara and we get a lot of patients from the Central Coast, from the southern part of the coast at Barara because it's hard to find doctors on the coast. And we're just sort of over the river, you know. And I just wondered, and so of course they live on the coast, so they meet that eligibility. And of course, we're not necessarily, we weren't open on Sunday. We're try to be open 7 days a week, but we're not. necessarily, because we can't find doctors ourselves. And also it's quite hard. It's a bit of a drive, and for people who are unwell, it's a problem. So could we liaise with you about HITH, even though
Yeah.
we're not on the coast?
Yeah, absolutely. Yeah, so I didn't mention that, but I did show the map. So we can take anyone out of area. So even if they lived in Berowra and they wanted to come to our service in Gosford every day for their treatment, we could see them by clinic visits. We can't visit Berowra, but we can get people to come to them, and that's more common for people in the north of the coast. So there's that fuzzy border around sort of Bonnells Bay and Currumbong, where we can't quite get to, but people come to our Wyong clinic and we can treat them every day that way. And certainly if you, anyone who lives on the coast qualifies for sure.
Thanks, Ellie.
And is there an age limit for VCAT eligibility as well?
Yeah, that's a really good question. I breach the age limit all the time, but I'm the director, so I sort of have a phone a friend. Oh, do you mind taking this 12-year-old and just keeping an eye on them for me? And I think technically they should still be adult. We're not really doing kids, but they're all ED trained nurses, so they're a lot more comfortable than our HITH nurses for younger cohort. But we're not really advertising for kids on VCAT.
Yeah, okay. And sorry, just one more question. Just the capacity for VCAT, especially like the Friday afternoon special phone calls. Yeah, so what's the capacity?
As I say, they're really underutilised. So they have between sort of 7 and 15 patients on daily. They're funded for 20, and they have been 30 in the past. In fact, they were the old COVID community support team, and there was a time during the height of the pandemic where they managed 700 patients a day. So we want them to flex up. And if there's demand, we'll be able to build a case for more funding and more nurses to increase that service. So we want you to use them.
Thank you, Ellie.
Ellie, is it okay if I've taken screenshots of 2 of your advertising slides? Can I circulate those to my doctors in Berowra?
Yeah, please do.
Yeah,
CP, did you want to share?
Us, so,
Yep. I think Sandy will share the slides as well. We're happy for that to happen too. CP, do you want to share the rest of the talk, or do you want me to share and I can click forward?
No, that's okay. I do have it up here if I'm going okay. Sam made a good comment, use it or lose it. It's taken us, we're up to the 3rd year now of building it. And we've thought that a few times when nobody was using us. The use is starting to come in, but I think there's so much, there's just nowhere else in the hospital for patients to go. So we've had some grace with being under the numbers. So use it or lose it is now something to consider, but I think HITH's not going anywhere. It's too important to the hospital structure. And it feels a bit sneaky in a way, but like Ellie, I'm not sure why people aren't using VCAT. It's such a good service. And I think if us GPs can use it and not other people in the hospital aren't, it's fantastic for us just to keep filling the numbers with what's best for our patients. A phone call from a very skilled RN, such an opportunity for our patients if they're at risk of coming to hospital.
I do often feel like it's our own special private service. We don't want too many people to know about it, but it is such a wonderful service.
And just before I go into this case, if you guys want to read it rather than me reading it all, just echoing a few things that Ellie mentioned and how fantastic to have GP staff specialists. When we were going through our contract, we were really particular about the words that were used for our contract and the levels they were paying us. And it's nice to feel that we're pushing the GP agenda and specialty in the hospital, and having a medical director position for GPs is quite a lot of responsibility, but obviously it's gearing up now and working really well. So we're very proud of what we've been able to achieve with putting this service together and seeing Ellie present it all. It's so much broader than the old APAC. And I was wondering, I was going to check if you guys have your like buttons there with the thumb up or the thumb down. I just wanted to see how many people use the old APAC service. And just to remind everyone that cellulitis is still our bread and butter of what we can do. So it is the old APAC, but very few referrals now come from GP land for cellulitis. And I know Carmel used to come to our clinic, and again, thumbs up if you remember Carmel or the APAC team. And it was very regularly that they would attend our Terrigal practice. So a lot of those referrals have just dropped off. So that's the prime kind of candidate to come our way. One of the questions earlier was about clinically stable, or comments about who can come to HITH. And while we love clinically stable, we also now accept quite a range of complexity. So stability is really in the eyes of you, and we always will take your advice. So they could present really badly with all of the things if we wrote it down like we can in a case. But if you're seeing the patient and saying, actually, they're really well supported at home, and they're quite well, I think they would suit having hospital in the home. Those are the kind of patients we're still interested in as well. So clinically stable is really hard to define. We don't want someone at risk of sepsis, and sepsis is really important in New South Wales Health. So that's probably one of the big dividers. Like, are they well enough to be at home? We want people to be safe still in our service, but cellulitis, definitely something that we're not seeing from GPs that we could do, saves the ED attendance. So this patient here, 89-year-old male, we've read through all of this. Does anyone want to offer any thoughts on what could be going on? You can maybe just unmute and say. I'll put someone on the spot. Georgia, do you want to pick someone?
Oh, Chrissy, she's just walking in the room.
Chrissy can do
I
it.
can't see the slides on my computer, so sorry.
We can just look at the leg. It's an easy one.
Yes, are we going to say cellulitis there?
Yeah.
Yes,
Interestingly, that CRP is very high, isn't it?
Yeah.
And you're not always going to have the scans there. We can facilitate scans. We have to bring the patient into the hospital for it, but it looks like we're dealing with the cellulitis. We can do, if you referred this patient to us with less information, so you just said this part, we can take over the care as well, and organise those bloods, and get the scans if we need to. Ellie's put some stuff up
Sorry,
here.
Catherine, would you do the scans through the hospital or?
Yeah, in the hospital. So if a patient's admitted under HITH, with the double dipping kind of rules, everything needs to be done then in the hospital system. So we can't use an outside radiology. If you refer them to us, and before they get admitted, they're having scans done, that's fantastic as well. But as soon as they're admitted, it comes under our institution. So just to...
Sorry, because that's particularly handy if you had a patient like this and he's 89 and not as mobile, and to then send them to get x-rays and blood, it's a lot. So
it is a lot. It's much easier close to home for some of this radiology. I guess the other thing is, in this case, if he's 89, we're used to dealing with a little bit of risk as GPs. Like, if he came to hospital, he'd have all of these things done probably straight away. In home, we could do the bloods, try the IVs and see how it's going, and give us a little bit of time about trying to organise that X-ray and the CT. If we're thinking osteomyelitis, there is that clinical aspect. We would escalate that as an urgent scan if you were telling us that, or if we'd seen that. But some of these things with a more simple cellulitis wouldn't need all that radiology straight away. So it's case by case. And just the point here being this penicillin allergy, we are really the experts now with cellulitis. We've been dealing with it, our doctors on our service for, like I said, 3 years. We've had a really loyal team of amazing doctors working on our service, and cellulitis is something that comes up so often. We're often changing the meds from ED specialists. We're really mindful about all the things that can mimic cellulitis, and penicillin allergy, as you know, is quite common. There was a clinic being run up at the hospital to test patients, especially with the penicillin allergies. The specialist's on leave at the moment, but we try that first dose of the IV meds under supervision, and then progress from there. So this was a patient that came from an ED admission to our short stay unit. So 5 days already on Kefazoline, and the ankle redness, pain and swelling still there. We regularly review these, and our nurses are reviewing each day. So this again was an 89-year-old. The CRP's improved, but what were some thoughts from the group about what else could be going on here?
I might just comment there too. We'd usually expect a simple cellulitis to turn around within 3 days. So often we've got people only just for 1 or 2 days, and they're often running on a higher dose of oral Keflex. Usually 1 gram QID is equivalent to an IV dose with probenecid. So that's interesting in itself, but 5 days is too long for this case.
Yeah. So 1 to 3 days, the antimicrobial stewardship that we host on HITH is really strong, and the ETG is kind of our source of most of our recommendations, and yeah, 1 to 3 days total, and aiming more for the 1 day. And then we, like Ellie said, discharge on a high dose of orals. But this just wasn't budging. Complex cellulitis, when you've got diabetes or other things in the background, can sometimes be slower to respond, but 5 days with no response makes us think a bit broader. Does anyone...
Do we have a comment to exclude DVT as well?
Yeah, definitely. Any other thoughts about, I guess, mimics we're looking here, or other things that could be going on in the leg?
Yeah, CCF.
Yeah. A whole bunch of things, really. And our ED colleagues get a little bit upset with us when we say, actually, that's not cellulitis. Have you considered X, Y, or Z? And we're now at the point where we're a bit sneaky again, and we say, look, we'll accept them because we know that we're going to manage them maybe for something different, and it's probably easier just to take them on our service, and then we take over and do that. We don't want to miss some of the really important things like the clot. We don't want to miss an infection of the bone. We don't want to miss things that are worsening. The neck fascia is obviously something that's scary. So if we had a CRP that was going up, or a worsening situation, which does happen, we, because we're admitted, we have the opportunity to use the orthopedic surgeons, the vascular surgeons. We can bring the patient in and facilitate those reviews. We can get the scans, repeat the bloods, and we can have them admitted to a hospital bed if the bed's available, rather than sending through to ED. But it's really important, especially with antibiotic overuse, that we're treating the right thing. And as you mentioned, Georgia, DVT, we don't want to miss that.
Nice one, Sebashi, on the money. That was good.
Yeah, lots of pictures of the different things that we come across. So bilateral cellulitis, that is something that's very commonly referred to us as well through ED, and it always sparks our interest. That it is very uncommon to be both legs. So just we'll go through that mimics list. It can happen, but it's not the. It's more likely that it's not than it is. And venous eczema is really common, especially in the older cohort, diabetes and the like, and the weight that people are holding. So we won't just say, no, we're not treating that, but we do try and give good opinions and advice about how to look after legs like this. As GPs, I think ED doctors aren't always so up on some of these chronic problems that we deal with as GPs. And lastly, on cellulitis in particular, and some of the mimics, we're careful about cellulitis of the face. We have had a few people who've had a cellulitis along the jawline. We obviously don't want to be dealing with any airway compromise at home, and the periorbital cellulitis that can extend backwards. We don't want to be missing something important. So it's not an absolute no. We'd take your clinical judgment about how well this patient is, but often they end up through ED and are linked in before they come to us. And a common thing that's overlooked is, has your patient with the wound been in water, and making sure that we're covering for bugs. And we've had a few fingers in the last year that have just not responded, and it was on better history taking we found some exposures that we've had to broaden our antibiotics for. Oh, a good one here. ETG also backs up putting in place some early antibiotic use if you've got a patient with recurrent cellulitis. So we have a little cellulitis handout for our patients that goes through some of the early signs of things worsening, and we would encourage GPs to offer that prophylactic antibiotic as a backup for patients. So this is thumbs up, thumbs down time. So community acquired pneumonia, is it a HITH thing? Thumbs up, thumbs down. Lots of thumbs up. It's an interesting one. The new ETG is quite strict about who has pneumonia and who doesn't. So we really like that chest X-ray to prove it to be worthy of some IVs. And the stability comes in here again. Are they really well enough to be at home? Have they got an oxygen requirement or not? But it's certainly something worth talking to us about, and we can chat through. And it might actually be that we recommend the orals that you were going to maybe consider using, or whether we can just pop on VCAT and have someone watch this patient for a few days. Cellulitis, we know that one's a good one. Lots of thumbs up for that, no doubt. What about a patient with fluid overload in an aged care facility? Does HITH do aged care? Thumbs up or thumbs down? We do. That's still taking a little while to come through the hospital, but we do attend, our nurses will attend the aged care facilities, and aged care response team is fabulous. So CCF, definitely something we can do. The IV Lasix, the daily weights, blood pressure management, checking the bloods while we're escalating the diuretics.
Balancing acute kidney injury too, isn't it? Monitoring electrolytes, really important.
Yeah, 100%. Bilateral lower limb cellulitis we talked about, so thumbs up or thumbs down. That's good. We'll still take your referral and we'll still have a chat to you about it. Escalating COPD. Thumbs up or thumbs down. Yeah, so this one might be, like Ellie said, good for VCAT as well, to get the phone call. The COPD escalating is at risk of hospital attendance. We know from our stats that the coast actually has a higher predominance of COPD and a longer length of stay than across the state, and that's the same for heart failure. So it's frequently attending the hospital, and it is something that we could do at home, but it depends how unwell that person is. And as we know, sometimes that first day, the stats just plummet. We want someone to be safe. So even if they attend ED and are kind of prompt that you might be able to go to ED and then to hospital in the home, it's sometimes a bit more favourable for patients if they're thinking, I don't want to go to hospital. But definitely, again, call us and we can chat through how well or unwell your patient is. So an elderly fall at home, thumbs up or thumbs down?
This is a really good segue. Sorry, CP.
Yeah,
Sam's just asked, do you have any physios, OT, social workers on the team for assessment if involving falls concerns, not as a primary referral? So it might be a good time to talk about what Allied Health can do.
Yeah, definitely. So the elderly fall at home, often this ends up calling an ambulance. And the ambulance now, we have a really strong program, one of the best in the States actually, of ambulance calling through to VCAT. So if your patient was at home and they'd called an ambulance, they can come through to VCAT or HITH via the ambulance pathway as well. And like Ellie said, we have a group on standby through our Allied Health program. So we have a physio, an OT and a social worker. So if this person had fallen and have injured their knee, unlikely to be if they don't have severe pain or we're looking at a break that needs immediate management, the paramedics will often review, or if you as a GP have done a telehealth and think they're quite okay, but perhaps need some assistance with a new injury. So like hurt their rib, for example, you can certainly call through and we would put you on the Allied Health program, and that's a non-admitted or an admitted model of care. And there's a physio, OT, social work that can be involved in helping that person.
So they can also implement sort of a compacts at home, can't they? Or even Transpac with a rapid access to these home care packages. If we've had a person, we don't take self referrals, but we had one poor lady, 85-year-old lady, call through to Gosford Hospital Switch saying, I've just been sent home from ED with my broken wrist, but I can't make my meals and I can't get myself dressed. And so the Switch actually referred her to HITH to see if we could do anything. And our allied health team set her up with 6 weeks of home services just while she was recovering with her broken wrist. So that sort of thing, we're good for you to think about.
And we feel very strongly about that pathway because you can imagine that person coming into hospital and the deterioration that they could possibly have from an extended stay in hospital, in their pajamas, not walking much, not actually making their own meals, not eating their same food, losing those social contacts, everything that we mentioned at the beginning are really real risks for elderly people coming into hospital. The medications that we add, perhaps they're not sleeping, we'll give them something to help them sleep. It's really a slippery slide, having an extended stay in hospital. So we're really passionate about this program for Allied Health, and the team are just amazing. And there is medical governance behind it as well. So thumbs up or thumbs down, elderly for this same person, and they've had a head strike. Starts to become a little bit more uncomfortable territory. No one's committing on that one to the thumbs up or the thumbs down.
I can't work out how to do a thumbs down. It's all happy emojis.
We'll say absence to that. It's definitely not a no. Depends how you find your patient really and your referral again. Certainly a head strike on anticoagulation we wouldn't take because the risk is too high. But people do bump their heads quite often. And if you've reviewed them and you think they're quite well, and you just want someone to observe them, we take your medical handover on that. So it's just starting to extend that idea of where is our clinical comfort here and what's the alternative. And you'll obviously have a lot of obstinate older people who'll say, I'm not going to hospital no matter what. We don't want to take that risk if they're on an anticoagulant, but there is this grey area where we're really interested in your expertise and your knowledge as the GP. Are they actually still okay for HITH and can we monitor them? So it's not an absolute no, but it's really on the edge. So the Allied Health program, Rapid Access to Care and Evaluation was the old name for the RACE program, but a lot of the crux of it's the same. We're just trying to stop too many different divisions under HITH. So the patients come under HITH and it's an admitted model of care. There's medical governance, there's the physio, OT, social worker. We try and give the patient what they would have in hospital, but at home. And it's been a great success to have access to the packages, which you can't otherwise get unless you're an admitted patient.
I might just say, sorry, yep. CP, I can see Sarah Collis online. Great to have you online this morning. A really important program to assist the Aboriginal and Torres Strait Islander patients who really don't want to be in hospital, but they tend to present younger and certainly qualify for my aged care and other home care packages from age 50 rather than in the older non-Aboriginal cohort. So yeah, really important to think of us for First Nations patients.
I think there was a question from Sarah. Was it a?
Sorry, I was trying to figure out how to wave. Sorry.
Hey, there you are, waving. Hi. Welcome.
Virtual wave, everyone.
Yeah, it's the forefront of every single program that we establish is how can we offer this to the community, but especially Aboriginal community locally, First Nations. So everything that we've set up, we'd love everyone to access, but particularly the community. Case example, 89-year-old male, have a little read through there. Came to us with some really specific goals. So really important holistic care coming through this program rather than just discharge home. We aim for an earlier discharge from the bricks and mortar hospital service to try and get the hospital level care starting earlier, so it's establishing in the home. But it's really fantastic to actually have that physio in your home and see what are the true things that you'll be able to manage at home with your rehab plan or the OT. What can we actually do to stop you from falling again? And unfortunately, as does happen, a social change has happened for this patient with the wife passing away during the HITH admission. So a terrible outcome for the patient, but having, again, this wraparound support at the time was definitely helpful. So you can see kind of the breadth of patients that we're seeing now, very different to the old APAC model, and really it's a very caring model. HG, this is something that we've kind of taken over on the coast. In fact, it's really hard to get the women off our program because they do love it so much. We get a lot of positive outcomes with this, but it's really about stabilizing the medications. We're aiming for a 2-week program now on HITH, fluids when needed. But we really focus on medications. We pay for the medications through health while they're on the service, and we try and stabilise and recommend as per the HG guidelines, and we liaise with ONG, do the bloods, do the monitoring. Do we have much time for this one? Well, I'll just skim through this one quickly because it's a very classic case of HG. We were getting a lot of referrals for nausea and vomiting in early pregnancy, and we do take some of those, but we probably more give advice and send to VCAT for a few days if needed. And again, we're all about hospital avoidance, and we know from when the program was set up that these women were bouncing in and out of ED for extended lengths. So we're trying to avoid that cycle. And this is just a little idea of how we try and manage them. So it's a really structured program for HG. And bowel care is a big thing. The recent conference we went to for HITH, they were talking about enemas if the bowels aren't open after 2 days. So we're much more aggressive with bowel care, and it really does impact that nausea and vomiting. Lots of changes to the medications, and we use the guidelines that are here. We've gone through a few of these. A nice hospital avoidance case, 53-year-old pyrexia unknown origin, CRPs again quite high. GPs called through for this one. Is this appropriate for HITH? There's been a discussion with the doctor. So there are a few features here that make us worry about sepsis and escalation. So this one's kind of been monitored by the HITH doctor with the referral. We've tried to work out the diagnosis through ED. We've got the ID consultants involved, the PIC lines, and then home with our team. We can do direct to HITH. We had a GP referral a couple of weeks ago who's was seeing a patient with infection, osteomyelitis, and their specialist from Sydney had recommended a course of treatment, and they were hoping that could be arranged through our service. So it takes a little bit of work around. Our ID is involved locally. We have the patient come in and get admitted, and we do a PIC line, so it's all from living in the home rather than being in hospital for that process. Have a little look through here. I'm conscious that we're running out of time and we'll have some questions. So this one really is just showing again the breadth of patients that we're seeing on HITH now. So they are coming much more so from a background of complexity and increased needs. Very different again from the APAC quite well person needing some antibiotics. All of these really important things that we would perhaps have flagged as not being stable in the past and not appropriate. But the reality is this is what the hospital is seeing, and we'll see with Ellie's slide on ageing population. It's really unusual now for patients to come into the hospital that don't have quite a few comorbidities. And did really well with the support of the team being wrapped around, so the allied health team, but also the governance of HITH.
Yeah, this was a really interesting case, as she was actually discharged with nothing to start with, and we picked her up. Her neighbour used to work for the COVID community support team and thought, this is a disaster. I'm going to call VCAT,
and
see what
risk of hospital
they can
again.
do. Yeah. And then everything picked up then, and great wraparound service.
The hospital a couple of weeks ago was sitting at 60 or so patients waiting for aged care facilities. And they've had to really juggle how they're going to manage that. But if you look back sometimes at the process, the longer that someone was probably at risk of needing aged care and escalation of care. But if you pop them in hospital for 2 to 4 weeks, you wonder where that risk actually pushed them. So we want safe return to home, but being at home really is the best for a large cohort of patients that are coming into hospital. Just jump through these. VCAT, we've heard about them, lots of things that we can do with VCAT.
So that was for that particular case, but yeah, that was a really complex case. Sorted her out with HITH, both HITH and VCAT. Yeah, good example.
So we'll just return to the beginning and give you a few ideas of the things that we do. We see a little bit of diverticulitis. We just need to be sure we're not dealing with something that's going to perforate there. HG, lots of septic joints, heart failure, it's something we're looking to move more closely into. Falls and frailty, we're very keen on seeing patients in hospital that want to discharge against medical advice and make sure there's not something we can offer at home. We came up with this innovative stay home against medical advice form. So often we do have people at home and they love being at home, they love being treated at home, but very occasionally something takes a turn and we recommend they come back to hospital and they don't want to do that. So we have them sign the form in the opposite direction. And again, we're just not IV antibiotics anymore. We're a whole range of things that we do. So the take-home message really is if your patient's well enough to be at home and meets those original criteria over 16 in the catchment, some element of being well enough that they can manage at home with that most likely once a day RN visit, give us a call and see if that's something we can do.
It's interesting to discuss a couple of these ones.
With the crosses.
Yeah.
Iron is
IV.
probably very topical. And we understand that there's a lot of GP practices who can't do or don't offer iron infusions, and the patients are left waiting or trying to find somewhere. But we try and stick to our guidelines for HITH, which is at least a day's stay. So IV iron doesn't normally meet our criteria unless there's an exception to it. And again, the exception is would they otherwise attend ED or hospital?
Yeah, we're a hospital substitution program, aren't we? So you wouldn't admit a patient into a ward bed for an iron infusion. But if they need an iron infusion on HITH for another reason, then we'll organise that to supplement their care. Yeah,
and that's the same with blood.
is the same. Yep.
Yeah, a few of these things are not the reason you would refer to HITH, but we do these on HITH like you would in a ward. The vasopressors, I would assume they're not well enough really to be at home if we're doing that level of care. And we can, we are moving into some end of life work as a palliative care. So if you've got someone in an aged care facility and you think they would need a bit more supervision or help or care that you're not able to provide as the GP, that's something we would be interested in hearing from as well. And just a little bit on who we decline. There's also some variability and we take everything case by case. The active IV drug use is for the safety of our staff, and it's something we would discuss with you again. We have had some really successful cases that Ellie and I are very proud of, where we've treated people who are active users for life-threatening needs who wouldn't come into hospital. So it's not an absolute no, it's about working out how we can safely do it for everyone involved, and clinic visits. And we've had quite a large handful of people who are active users of a range of things. And even with PICC lines, we use the tamper-proof PICC lines. People have been traditionally very respectful of getting the treatment and having a PICC line. There's been a couple of cases where we've chased people around the state with their PICC line still in, but we would still err on the side of let's be compassionate and try and think about how we can help people in all of these situations, rather than an absolute no. But it could well be that they don't suit our program for a few of these reasons. And the 4-hourly OBS, it's a whole new conversation, but there are some services who are offering more of the remote monitoring, and it's certainly something we're looking into, the pros and cons of it. So it depends what OBS and why.
We don't do that yet.
So back to the beginning, how to refer to us.
Oh, that's an old slide too. Maybe a couple of questions, or Georgia, you
we'll
can
leave it open.
Yeah.
Yes, I've got glowing reports from the audience. So Sam summed up beautifully, brilliant presentation. I knew you guys were great, but hadn't realised how much you had grown and developed. Thank you, amazing service. So it is an amazing service that you do, and thank you so much. And you guys are like the powerhouse behind this, and have worked so hard and long hours, and we appreciate you. Also, one more question too from Sam. So yeah, can GPs do it? An important question. Can GPs do a telehealth and bill while they are admitted under HITH?
Oh, that's a great question.
Yeah.
Just like when you're admitted to a hospital ward bed, you wouldn't usually, bill for your patient during an admission. We're the same. We would never ask the patient to see you while they're admitted under us. But if it happens to happen, I think it's agreed that, nobody's going to audit it. It's very hard for Commonwealth to know that there's a state episode of care happening, so that nobody's going to get in trouble for it, but it's not encouraged. But if you're looking after something that's unrelated to the HITH admission, that's where we can justify a GP appointment. But it does get a bit blurry if you don't know that they're admitted under HITH and you change the medications and we don't communicate well. There has been some glitches with discharge summaries and letters getting to you guys that we're always trying to get right. So please let us know if you're not receiving those letters or discharge summaries still. Is that fair enough, CP?
Yeah. We've had a few different variations from Ministry of Health on that question, Sam. So originally it seemed a lot more lenient, and the last time they put out messaging, it was becoming a bit more strict. And then there was something from the GP college to GP saying you can't see people while they're on HITH. So like Ellie's saying, you're not meant to, just similar to if someone was in hospital. But if it's an exception and you can say it's not related to the HITH stay, nobody will follow you up. And similarly, if a patient's seeing a specialist, say an ophthalmologist for their 6-monthly glaucoma checkup, and it happens to fall within their HITH stay, it's again a grey area, but we think if it's not related to HITH and it's really important that they attend that appointment and it's going to affect their health in some way, then we let it slide. We're not chasing it up, but that's how we interpret it.
Beautiful. And more thank yous from everyone, but no, that was invaluable, and especially this slide.